All right. Hey, everyone, and welcome to our next video on evidence-based medicine. This time, I'm going to be talking a little bit about clinical reasoning, but really mostly about all those numbers and different values that they keep on asking you to calculate and what they actually mean and how to actually use them in the clinical setting. Let's dive into it. Okay, so in terms of clinical reasoning, basically this is the process between the patient coming in to see you and you actually making the diagnosis. So we typically frame it as you being a GP or maybe an intern in a hospital, because interns or residents are usually the ones who are tasked with seeing the patient first. And it basically means you start with almost nothing and you need to come up with a diagnosis through that process. So that's a really, really important process. Now we're going to start off that process by taking history. I should also have written an exam there. So we take a history and an exam based on what we know about the patient. And then we think about investigation. So investigations are going to run the whole gamut from very simple ones to very involved ones. And so we need to use a little bit of our judgment when it comes to which ones we actually want to be using on this patient. And we'll be talking about that in a sec. So what are the issues with this? So we can have an incomplete history or exam. We can have a failure to consider alternate diagnoses. So you sort of hyperfixate on one diagnosis and then you don't pay adequate attention to other signs, especially if you start to discard signs which are sort of conflicting with your primary diagnosis, because you never want to be doing that. If there's evidence that your diagnosis is wrong, or at least the one you're thinking of is wrong, then you really need to be on top of that. And then personal factors. So there's a lot of different things that can go into it, a lot of moving parts, but basically you want to make sure that you're acting at your best and that the patient, well, not that you can do about the patient, but you can make sure that you're performing as well as you can. And really quickly, with the test, I think you guys may or may not have been introduced to the idea of diagnostic and versus screening tests. Basically, to make it really simple, screening tests are tests that we do on people who we have no idea if they have the disease or not. And we have no particular suspicion that they have the disease. So we just do it to everyone as a matter of course. Diagnostic tests, we think that they have the disease and we want to confirm them. So it's basically based purely off the function of the test. The same test can be used as a diagnostic or a screening test, depending on whether we think the person is likely to have it. Okay, this is actually copied from our slides. I assume they'll probably be pretty similar, if not the same, to the ones that you guys use. And that's basically because there's not much more for me to say about them. I will say the framing can be a little bit hard to understand, but it's basically almost a hazard with having overly buzzwordy or stereotypical presentations, which is where you start to get really anchored in your context and you think, okay, well, you know, this case sounds just like this thing or that thing. And then you start, like we said before, hyperfixating, ignoring findings that go against that diagnosis, and not considering alternative diagnoses that are also fit by the presentation. Okay, so this is the real meat of the thing. So we've got 6 different numbers or different values that we're going to talk about here. So the first, each of them is paired. So there's like a positive and a negative one. So we have first sensitivity and specificity, which hopefully you guys are already familiar with. So sensitivity basically means if you can think of it almost in terms of like they're pretty useful names because sensitivity is how sensitive the test is to the disease. So if the test is looking at a whole bunch of people, if it's really sensitive, you can imagine it will pick up pretty much everyone with the disease. Okay, and if it's not very sensitive, it won't pick up many people with the disease. Specific and specificity refers to the ability of the test to only pick people who have the disease. So if you don't have disease, what's the probability that you'll test negative? So these are inherent to the test. If you guys have a look at a rat, if you actually look at the paperwork that comes with it, you'll find that they list the sensitivity and the specificity. They'll never list the positive or negative predictive values because those are based on populations. But the sensitivity and specificity are inherent to the test. And so those can be lab tested, and they actually are lab tested, and then, you know, provided with all sorts of medications and tests and that sort of thing. Okay. So yeah, and we'll talk a little bit about how to remember which ones are inherent and which ones change with populations in just a sec. But suffice that to say, Sensitivity, if you have it, will you get picked up? Specificity, if you don't have it, will you avoid getting picked up? So in terms of positive and negative predictive value, this is basically saying, okay, well, we've done our test, we're looking at our data set, and all those people that tested positive, how many of them actually had the disease? And then all those people who tested negative, how many of them actually didn't have the disease, okay? Now, it can be very easy to sort of confuse the two. There are two ways to look at it. So on a sort of abstract level, we can talk about sensitivity and specificity. We start with the disease population, so yes disease or no disease, and then we look at how the test interacted with that. In the predictive value, we start with the test results, and then we check how they match the disease. Okay, so sensitivity and specificity are basically they're evaluating the test against the disease, because we're starting with the disease and saying, okay, well, did the test do well? And then the predictive value is almost saying we start with the test and then we see, did the disease do well? Did the disease show up in all our positive results, and did it fail to show up in all our negative results? Yeah, and so that will actually change. And the easiest way to remember that is to just go to extremes, okay? So imagine we have a population of 100 people. We're doing a test for COVID and they all have COVID, okay? So if the sensitivity of that test is 99%, so 99% of people with disease will test positive, then the sensitivity of that test is, then we're going to expect one person with a negative and 99 people with a positive, okay? Now, since we have no people without the disease, the specificity is sort of undefined, okay? But suffice it to say, at least it's experimentally undefined. If we had 100 more people who didn't have COVID, then we could say with some confidence that they would, if it had a 99% specificity, that one of them would test positive and the rest would test negative. But if you look at the positive predictive value, okay, if you consider a population of people with 100 people with COVID, you would say that the positive predictive value is 100%, because those 99 people, all of them had the disease, and the negative predictive value is 0%, because that negative person did have the disease because they all have COVID, okay? And then if you flip that to the opposite population, so remember the other population we were considering was one in which 100 people don't have COVID, they're all COVID-free, we'd expect to see, again, just using an arbitrary number of 99, we'd expect to see one positive test and 99 negative tests. So now all of a sudden, the positive predictive value is 0%, because the one person who got a positive test didn't have COVID, and the negative predictive value is 100%, because everyone who got a negative test didn't have COVID, okay? So the predictive value is very dependent on population, and you can remember it sort of that way, okay? So either way works for you. Maybe neither of those works and you find your own way. Either way, as long as you find something that allows you to remember what characteristics fit which types of test, and how to actually calculate them, okay? Speaking of calculation, likelihood ratios are a little bit less intuitive. So you sort of just have to remember its sensitivity over specificity, and then where you put the one minus depends on whether it's positive or negative. You don't need to understand that on a base level, like a mathematical level so much. More important is understanding that positive likelihood ratios, you want them to be very high, because the idea is the higher the likelihood ratio, the more likely that a positive result is actually a true positive, okay? And vice versa for negative likelihood ratios, okay? So you want to have either a very high positive likelihood ratio or a very low negative likelihood ratio, because those are useful to you. If the likelihood ratio is sort of hanging around in the middle somewhere, then it's basically useless to you, because if you do the test, then it's not going to actually increase or decrease your probability of the patient having the disease much at all, okay? That might make a little bit more sense when I show you where we have the next slide, which is a nomogram, okay? So basically the idea behind nomograms is tied into the idea of pre and post-test probabilities, okay? So pre-test probability says, okay, this person's coming off the street, I've had a look at their exam, I've done a history on them, and I reckon that the probability of them having this disease is such and such, okay? And if we then say, okay, I'm going to do a test with a certain likelihood ratio, then the post-test probability is the probability after we get that test result that the person has the disease. Sorry, that the person has the disease. There's no or. And the way you use it is you just basically draw a line. So I don't know if you guys can see my mouse on the recording, hopefully. Either way, imagine we start at, let's say, a 10% chance over at the pre-test possibility, probability, I should say. And then we pick a test with a likelihood ratio of, let's say, 50, okay? So if we do that and we give it to our patient and we get a positive result, that means if we draw a line from 10 to 50, you can see that it's basically going to draw a line straight all the way to about 85%. So that's a really, really useful test because it means that we can find a patient who has a very low chance of the disease and then do the test and have a really high degree of confidence that they do have the disease. At the same time, if we find a test with a really low negative predictive value, so let's say it's 0.2, if you draw that line down, you can see it goes 10 to 0.2, and it's on basically 1%. Okay, so remember, positive is for ruling in, which means it increases the probability. So we want to say we want to do a test to confirm that this thing is probably what's causing the problem. And negative predictive value is for ruling out. So we do it, and that really drops the probability, and that means that we can say, okay, the patient almost certainly doesn't have this thing. Okay. Now, the thing to remember here, and this ties back into when we were talking about clinical reasoning, is that not every test is actually relative. Okay, so if your test has a probability, let's say your patient has maybe a 20% chance of having a disease, and you do a test of with the likelihood ratio of 1, no matter where you draw a line through that nomogram, they're going to have the same possibility afterwards, because basically our test is useless. It doesn't tell you anything positive or negative. You want to skew things out to the side, and that way you actually either increase or you decrease the probability of something happening. Okay. Yeah, and so obviously if we get a test, or we have the possibility of doing a test, and it doesn't do much to shift it, especially in patients who are positive. So let's say you have a 70% chance that this person is having say tricuspid regurgitation or something, and then you could do a certain investigation, but you know that it only has a likelihood ratio of, let's say, 2, and that will only bump you up from about 60% to about 80% or something like that. Then that may not actually be super useful for you because they're already starting with a greater than 50% chance. So you want to be careful because obviously in the private system, you're wasting the patient's money. In the public system, you're wasting everyone's money. And we want to be very careful with our use of healthcare resources. Now, of course, in real life, it's very hard to get a pretest probability that is that high. So you really got to pay attention to the history and exam, basically. But yeah, hopefully that clears that up a bit, especially with all those values that we talked about before, and that you guys have some idea of how to apply these things in practice. Thank you and have a good day. See you in the next video.